This week on the BackTable podcast.
Quite honestly, my impression is this may just be the tip of the iceberg in terms of the types of patients that we're leaving untreated, because as I understand it, nearly half the patients who are referred for an invasive angiogram for evaluation of chest pain end up not having significant epicardial coronary disease. So this is a huge, huge subset of the patients that are referred for an invasive evaluation of chest pain. And yet we don't currently have particularly fantastic treatment options. Obviously, medical therapy is what we can offer, but it just doesn't seem to address the majority of our patients. They keep coming back with recurrent symptoms to the ED and get admitted to the hospital, have multiple invasive procedures done with the same results, no significant flow of the epicardial coronary disease. And what do you do with these patients? It's a huge, huge challenge.
This show has been sponsored by Shockwave Medical. To learn more about the COSIRA II clinical trial, a multi-center randomized trial evaluating a novel therapeutic option for treating refractory angina, please visit shockwavemedical.com/clinical-evidence/COSIRA-2/.
This is Ziad Ali from St. Francis Hospital and Heart Center in New York, and I'm joined by my good friend and colleague, Khatri, recently immigrated into New York from Cleveland. Got a smile on his face. We were just talking about all the sirens in the background. He's getting used to it. And here we're talking today about something that I think is really at the core of what we do as interventional cardiologists. And that's talking about refractory angina and this ongoing symptom issue that we have with so many patients. So Jai, welcome to BackTable and thanks for joining us today.
Super. Thank you, Ziad. It's so great to join you today. Thank you, BackTable, for arranging all of this for us. So yeah, this is what we got into this career to do, to take care of chest pain, right?
Yeah, so let's start with that. I mean, you've been a complex PCI operator working on some of the most complex coronary disease. You've been invited all over the world to treat blockages in the arteries that cause refractory symptoms. Tell me about what sort of problem or burden is chronic angina before PCI and then after PCI?
Well, I mean, I think we start from the basics. So chest pain brought on by effort or exertion is sort of the bread and butter. This is what we do on a daily basis. These are the kind of patients that we see in clinic, the ones that we see in the hospital, the ones that are on our procedure tables. And it starts with the basics. So we're all internists to start with, right? So we have medical therapy to treat angina, and it behooves us to make sure that we've treated our patients as effectively as possible before they end up getting a procedure done. Obviously, some procedures are primarily for diagnosis and some are for treatment. When you do an invasive angiogram on a patient, sometimes you find disease that's easy enough to treat percutaneously, and we put in our stents, and very often patients feel better. There are instances where patients have disease that's far too complex for effective revascularization with stents, and those patients we send off for bypass surgery. And then there are the patients that have all of these things already done, and yet they continue to have symptoms. That's really what we're here to talk about today.
So let's start with obstructive coronary artery disease, what we really see on a day-to-day basis. You know, it's still the most common manifestation of ischemic heart disease. It's accounting to 60 to 70% of what we find on the angiogram. And it's a big population burden, right? 18 million patients with coronary artery disease, 2/3 of them with some sort of symptomatic disease involving obstructive epicardial disease. On this global level, how can we differentiate what's truly ischemic heart disease from what's non-ischemic chest pain? What do you do in your clinical practice? How has that evolved over time?
That's really sort of been the real big evolution in our field. So classically, treadmill stress testing, stress echocardiography, SPECT scans were the mainstay of outpatient evaluation of these patients. That's honestly become far less of our clinical practice currently. We do a lot more PET scanning, stress MRI. We find that these tests are a lot more objective in terms of avoiding some of the pitfalls of artifacts and false positive results, false negative results. But that's evolved, and honestly, that it doesn't necessarily apply to the vast majority of patients because access to these types of tests are not readily available throughout the country and throughout the world. So this is an ongoing issue.
So let's shift to the other population, which is sort of newer on the block, and that's this angina with the non-obstructive coronary disease. So maybe not someone that you see so much, but a lot of hospitals now have these chest pain clinics, and they're doing investigations for microvascular disease, coronary spasm. How much of a burden do you think this really is? And how do you find and treat these patients differently to the patients where you're such an expert at treating obstructive coronary disease?
I think that that's still something that we're starting to understand a little bit better. And quite honestly, my impression is this may just be the tip of the iceberg in terms of the types of patients that we're leaving untreated. Because as I understand it, nearly half the patients who are referred for an invasive angiogram for evaluation of chest pain end up not having significant epicardial coronary disease. So this is a huge, huge subset of the patients that are referred for an invasive evaluation of chest pain. And yet we don't currently have particularly fantastic treatment options. Obviously, medical therapy is what we can offer, but it just doesn't seem to address the majority of our patients. They keep coming back with recurrent symptoms to the ED and get admitted to the hospital, have multiple invasive procedures done with the same results, no significant flow limiting epicardial coronary disease. And what do you do with these patients? It's a huge, huge challenge.
So let's move a little bit on from there and talk about how you're currently treating obstructive coronary disease in the outpatient clinic. So your patient comes in, they've got angina, you think it's legitimate, you're picking your test of choice, whether it's CT or PET or MRI. Tell me about modern day medical therapy and the impact of that on your practice.
I think that being involved in the clinical trials that we're involved in for management of patients with refractory angina have honestly made us much better at the medical management of these patients, because most of these protocols mandate maximizing patients on at least 3, if not all 4 classes of anti-anginal therapies, or documenting intolerance to the drugs before we can enroll them in trials. So that's honestly helped us be much more cognizant of opportunities to help our patients. So maximizing beta blockers, calcium channel blockers, oral nitrates, ranolazine. These things do help patients. Not all patients can tolerate these things, and they're not effective in all patients, but to not offer these up front and go straight to an invasive strategy, I don't think it's necessarily fair, and it's not necessarily giving the patient every opportunity to get better.
A lot of people have analogized this to sort of people with knee pain who need a joint replacement. You've heard this before. They're like, well, you're struggling along with a cane now because your knee's hurting so much, and you're taking, 2,400 milligrams of ibuprofen every day. Obviously, all those drugs have side effects, and people are able to go and see the orthopedic surgeon to get scheduled for knee surgery. Do you think that's a valid analogy for coronary artery disease, or do you think that medical therapy doesn't have the same, A, potential side effects, and B, should be mandated before revascularization?
I think that's a great question. And I would tell you that every patient is different. There are patients that simply cannot tolerate even a negligible dose of beta blocker without some intolerance. And there are patients that are on 200 BID and they're doing just fine. So I don't know that I necessarily know how to answer that, other than I feel that before I want to subject a patient to the risks of an invasive treatment strategy, I want to at least have explored this in a responsible way with the patient to make sure that we haven't missed an opportunity.
It's amazing. Just as I asked you that question, I was thinking back into my own practice and thinking how much of any outpatient clinic appointment for a patient with angina or for a patient who's being revascularized is me trying to parse out what side effects they're having from the drugs. I mean, you've got worsening kidney function, you've got erectile dysfunction, you've got shortness of breath with the antiplatelet drugs, you've got muscle aches from the statins. The medical therapy arm is clearly very efficacious and valuable, but it's not without its costs. And so, like you said, I really appreciate and echo the fact that every patient is different, and there's going to be some patients who need a knee replacement who just want to have it right away because they want to get back to their life. There's others going to say, well, mine's not so bad, I'm okay with taking some acetaminophen every few days and managing. So I completely understand that and echo with you your thoughts.
The other way of thinking about this is patients have varying expectations of what's lifestyle limiting. So, right, I've got patients that feel perfectly fine but insist on being able to mountain bike at 3,000 feet, right? So that's the only time they experience angina, when they're in their vacation home. But that's their symptoms that are lifestyle limiting, right? And then there are patients who have angina getting from the waiting room to the exam room. Everybody's different in terms of what they expect and what they want. And so our treatment has to be tailored accordingly, with everybody understanding the risks and benefits of all these options.
So let's dive a little bit deeper now. We've talked about medical therapy, we've talked a little bit about epidemiology, but let's get into the nuts and bolts here. And so you're in the cath lab, right? Or I'm in the cath lab. I think when we have straightforward focal epicardial disease, I think it's pretty clear the evidence, both anecdotally and scientifically, shows that treatment of that with a stent is extremely efficacious at relieving chest pain and improving quality of life. But over the last decade, with the appropriate use criteria, with pushing medical therapy before getting to coronary angiography, partly because of insurance issues, both you and I are seeing a lot more advanced atherosclerotic disease. Instead of this focal disease, we're seeing a lot of diffuse disease. And as you know, 1 in 5 patients actually comes with a completely occluded artery, which is a completely different kettle of fish when it comes to revascularization in terms of risk, and when it comes to how to treat these patients medically and post-procedure. So tell me about managing that group of patients, the more complex atherosclerotic patient.
I think that's sort of true everywhere, right? So some of this is probably from deferral of care. Some of this is just from the fact that our patients are older and have more associated comorbidities. Many of these patients are already post-CABG, which we all know seems to accelerate disease proximal to the touchdowns of the grafts. So there's a bunch of different factors that are playing into this, but the bottom line is that PCI in a type A lesion is quite different than PCI in a diffuse multivessel patient that's got multiple bifurcations and maybe a CTO. And doing these types of cases ad hoc without having a proper conversation with the patient and the family is probably not the best practice. I think that we tend to stage a lot of these cases because it requires a much more involved conversation with the patient in terms of what we can expect to get out of the procedure, because it's not as straightforward as a type A proximal LAD when you have diffuse multivessel disease with bifurcations involved. And also in terms of overall expectations for durability of the results, all of this needs to be, I think, discussed at length with the patient before we embark on these types of procedures, because we've all taken care of these patients where the results angiographically look reasonable, but the clinical results are, suboptimal at best. And setting expectations up front, I think, is important to make sure that everybody understands what we're getting into.
Yeah, I do exactly the same thing. I use a lot of analogies in my practice. So I tell my patients when they've got a focal blockage that basically it's a car accident on a highway, and once it's cleared up, the traffic's going to be back to normal. But if they have like more diffuse, high burden atherosclerotic disease, I'm like, well, this is kind of like a dirt road. And it's not so easy to rebuild the whole dirt road. We can maybe carve a path so that a car can go down it, but the likelihood of us ever getting to the point at which you can have the same flow as a highway is pretty unlikely. And I feel, using these simple terms with the patients or giving them analogies to help them understand what their atherosclerotic burden is really helpful. I take all my patients into the clinic, into my office, to show them the angiogram. I show them a normal angiogram first, and then I show them what their angiogram looks like to sort of help them put it into perspective. And I feel like something like that actually really helps them.
Yeah, no, I agree. I also think that it helps referring doctors understand some of our more thoughtful approach to this. Patients with multivessel disease, even if we have landing zones for stents that are moderately okay, the problem with those patients is often the runoff vessels are so poor that we end up creating situations where we haven't actually revascularized them. We've just made their epicardial vessel look pretty. And that's something that a picture tells 1,000 words. It's something that I think it's helpful both for the patient as well as the referring doctor to see what we're talking about here.
How's your treatment algorithm of sort of PCI versus CABG in these more diffusely diseased atherosclerotic multivessel disease patients?
Yeah, I think that for most patients that are relatively young and diabetic, I would always want our surgeons to take a look at it to see what they think they could offer, because unlike us carving up that dirt road, they're only going to interrupt a small segment of that coronary artery. So if they can find a place to touch down a graft, I think that they honestly cause a less harm to the downstream flow of that patient, as opposed to us stenting 60, 70 millimeters of vessel and embolizing a bunch of stuff downstream. So I think that if there's ways in a relatively healthy diabetic patient with diffuse disease to get surgery, that's always preferred. That's not what we typically see. We see a lot of 80-plus-year-old patients with lots of comorbidities that have poor targets. And for them, it's a much bigger challenge in terms of what to do and what's actually worth the risks involved. And that's where these conversations can get quite nuanced.
Yeah, it's if you think about the patient with obstructive coronary artery disease that requires treatment, I mean, it's a legitimate patient level burden, right? For first of all, they've got to deal with the symptoms. Second, they've got to deal with the procedures and the potential for repeat procedures. So it's a leaky faucet that might keep leaking. You have to tell them that. They have a lifelong medication load. So you can see how this really impacts their quality of life. It's their functional impairment, the psychological impact, and not to mention the financial burden, right? Coming to have a repeat procedure over and over again or have repeat investigations isn't without financial burden on patients. So I think we're doing a good job in interventional cardiology trying to figure out who benefits most from PCI and who may benefit less with PCI rather than just with medical therapy. Things like the PPG that are coming out, the pullback gradient. CT has been incredibly valuable to look at the overall plaque burden to see whether we can actually improve flow. Of course, the volume of the coronary arteries, all of those things play such an important role on whether or not we're going to be able to achieve our goals. So let's talk about the patient that you can't achieve your goals, right? You've spent 4.5 hours doing a very complex epicardial retrograde. You feel like you've just won the championship when you walk out, and then they're back in 2 weeks. You're sort of holding your breath a little bit, and you're like, so how do you feel? And then they come out with, well, I really kind of feel the same. So that sigh, I know that sigh. So what's your algorithm then? What do we do then?
Yeah, so that was sort of the impetus to get us involved in some of these clinical trials, because that is not a terribly uncommon scenario where you've done everything for a patient. You've maximized their meds. You've had a surgeon take a look at them. They've been turned down for surgery. You've done a rather elaborate percutaneous procedure on them that took hours to complete. Results are good. They come back to the clinic and they don't really feel any better at all. And sometimes they feel worse, unfortunately, because they've had some sort of a peri-procedural event on top of everything else. And now you really are kicking yourself because you're like, gosh, what are we going to do to help this patient turn the corner here? And that's where some of the clinical trials that we've gotten involved in come into play, and we can certainly get into that.
Well, here's where I want to introduce the concept of the coronary sinus reducer, which I know you're familiar with because this is a new implementation of a relatively older technology. I think the coronary sinus reducer was first introduced in the early 2000s as a concept and conceptually came back to a minimally invasive, the Beck surgical procedure back in the 50s. So there's actually a long history of it. So why don't you just summarize for the BackTable viewers and audience, what's a coronary sinus reducer?
Well, I guess it's probably helpful to describe the Beck procedure. So this is an operation described by a surgeon at University Hospitals of Cleveland in the 50s, where they would open the chest in patients with angina. This is before we had bypass surgery, and obviously no stents or angioplasty. They would open the chest, put a 3-millimeter stylet on the coronary sinus, and sew a stitch around the stylet, effectively reducing the diameter of the coronary sinus to 3 millimeters. And they described a remarkable reduction in angina in these patients. And this was a procedure that preceded any sort of revascularization options for patients. And it kind of went away because obviously bypass surgery came around. And then after that, all of the stuff that we do in the cath lab. It's only just sort of been resurrected in a percutaneous fashion in the 2000s and onwards, because we're at the point now, as we described earlier, that we have patients that have had all of these treatments and they're on all the meds, and yet they continue to have angina. And so it sort of resurrected this idea that, oh, okay, there's this procedure that was described back in the 50s that required surgery, but we can replicate that percutaneously. And the way that they do this is they've created an hourglass-shaped stent that is designed to fit in the coronary sinus. The waist of that stent is 3 millimeters, so it basically approximates what Dr. Beck was doing with his stitches. And the idea is that if you can deploy this in the coronary sinus, you can create a restriction of outflow from the coronary sinus, and the mechanism of how that should treat angina is still being explored and not entirely well understood. But there's some interesting evidence that's been presented in multiple papers, some of them in randomized clinical trials, to suggest that this may be an effective therapy for angina.
Yeah, so let's just talk about the evidence. I think the elephant in the room is the COSIRA trial, which was published in the New England Journal of Medicine. 104 patients who had exactly this type of refractory angina had evidence of ischemia, meaning there was actually a restriction in blood flow that could be documented through some modality, and they were considered to not have revascularization options. I think that's important, right? So this wasn't as simple as going in and just popping on a stent or getting a bypass. And 35% of the reducer patients improved by 2 CCS classes versus 15% of the sham controls, and their quality of life improved significantly. And this was the really sort of first, I would say, solid randomized evidence and proof of principle that this could actually work going back to Beck. And so that's really opened up this whole new era of potentially working in the coronary sinus, not only for obstructive refractory angina, but also for other things such as heart failure. And so tell us what about COSIRA II and how we're moving forward in the field with this technology.
Yeah, so COSIRA II is sort of the follow-up randomized clinical trial. Again, blinded, sham-controlled. The difference in this trial as compared with COSIRA I is that the primary outcome is exercise treadmill time. So one of the big criticisms of COSIRA is that the primary outcome was really a physician interpretation of patient-reported symptoms, so the CCS classification. And obviously there can be a lot of outside factors that can play into what a patient describes as their symptoms and what a physician interprets as the patient's symptoms in the clinic. So this is designed to be a little bit more objective in terms of determining what clinical benefit can we observe and measure in a reproducible way. So exercise treadmill time is sort of thought to be a better way of assessing the effectiveness and the efficacy of the device.
And I want to just take you back to the Beck procedure because, of course, they have their chests open, right?
Yeah.
And so one way to, move someone's state of mind is, sort of gate theory of pain. Hey, you have chest pain somewhere. Well, you had an operation, we cut your chest open, so now it's got to be better. Let's talk about the sham-controlled component of this and how important it is, specifically when your first outcome was subjective improvement of patient symptoms, but now also incorporating the primary endpoint of exercise tolerance time.
Yeah, I think that without a sham control, it's really, really hard to get beyond what the physical effect of the device is versus some of the outside influences of just having gone through a procedure are. There's just no other way to get that confounder out of there. And without taking that emotional part of it out, I don't know how we can really understand this, because a lot of angina and the burden that goes with it is emotional as well, as we've talked about. And it plays into this. And we have to have a way of looking at this very objectively so that we can be honest with our patients. And I think that the sham control is really the only way to do this. That's sort of been the bane of the existence of our CTO trials, is that the genie's kind of out of the bottle for CTO PCI, and it's very hard to do that kind of a trial at this point because no patient will accept it. These are patients that are in a unique situation where we've effectively exhausted all treatment options. So for better or worse, we have an audience that's willing to accept even this to see if they get better. And this is a way for us to be much more scientific about understanding what the device is actually doing.
I want to just talk a little bit about the procedure now. Both you and I work in the complex PCI and chronic total occlusion arena, and it's a little bit of like a box of chocolates. You don't know what you're going to get. You could end up doing a procedure that takes 15 minutes, or you could end up doing a procedure that's really very complicated, could take several hours, could involve multiple trips and multiple failures. But the procedure for refractory angina for patients with a coronary sinus reducer is really a lot more straightforward. Let's talk to the audience about how long it takes and how straightforward it is potentially to do a coronary sinus reducer versus doing a complex revascularization. And how do you now judge who should get what? When do you say, all right, this guy's got 3 CTOs, I've attempted one of them, it should really be enrolled in COSIRA II?
Well, okay, let's talk about the procedure. So the procedure itself in most patients is pretty straightforward. So it's an outpatient procedure done through an internal jugular puncture under local anesthesia. We usually take a multi-purpose catheter from the internal jugular vein into the coronary sinus directly, do a venogram, put in an 035 wire, and from that we can deliver the 9-French delivery sheath, and then it's effectively deploying a stent. So the whole thing is generally doable within an hour with a same-day discharge. It's a completely different scenario than, as you described, the sort of unknowns of what you're going to get into when you bring a complex coronary patient to the cath lab for a complex coronary intervention. You have no idea what that's going to involve and how long it's going to take, and had to have many hours a day blocked off for that. These are pretty straightforward and efficient procedures. Just anecdotally, so we were able to do several compassionate use cases before COSIRA was rolled out in the U.S. And Shmuel Benai and Keith Jackson from the company came out and proctored us, and we did 4 compassionate use cases. And this is a procedure we'd never done before. And we did 4 compassionate use cases from 8 o'clock to noon. We were done. And this is my CTO day where you typically schedule 2 to 3 cases and plan on not being home till like 9 o'clock at night, right?
Yeah.
And we were done with 4 cases by noon. So it's a dramatically different procedure.
On that same token, with any procedural efficacy, we have to balance safety. So what are the risks of some of this procedure? What are some of the things that you've come across that you tell the patients, or that you're either concerned about or not concerned about with using a coronary sinus reducer in this patient population?
Yeah, I think it's relatively safe. I think that this is an area that most coronary interventionalists are not particularly familiar with, advancing a catheter to the coronary sinus and delivering a sheath and a stent into that space is not something that most of us do. So there are some, risks of complication, particularly related to the wire migrating into a branch. There have been cases of tamponade from something like that happening. There have also been cases of the device migrating or embolizing. All of this is pretty rare. I mean, nobody's reported strokes or death, thankfully, from any of the trials that have been published to date. But it's not without some risk. So you can't say that this is a zero risk procedure. But overall, learning curve is quite easy, and the procedure itself is quite reproducible in terms of technical success. It's sort of a different concept entirely than going for your second CTO or a reattempt for a twice failed CTO and the peri-procedural risks that that involves and the likelihood of failing again. It's a different concept entirely. And so I use that to help determine for a patient what makes the most sense. I usually will lay out all of these options. Obviously, in the U.S., the big issue here is that this is not a commercialized device. It's something that's part of a randomized clinical trial, and patients have to be okay with the idea that they might get the sham arm.
Right. So that's, obviously a big issue at the moment. So let's talk about COSIRA II in a little bit more detail. So this sham-controlled, randomized controlled trial, are you guys enrolling at your institution at the moment?
Yes. So we finally got up and rolling towards midsummer. So we have a couple of patients that were in the initial phases of evaluating for screening. So this is something that we will offer along with a couple of other trials that we're engaged in for refractory angina. But this is something that I have a ton of experience with from all the cases that we did in Cleveland before I came to New York. I think that this is going to be part of our therapy moving forward.
So to summarize some of the trial inclusion criteria, these are patients who have refractory angina for more than 90 days with class 3 or 4 symptoms, have objective evidence of myocardial ischemia. It really doesn't matter how you do it, echo, PET, MRI, whichever one you want. And it's got to be in the left circulation.
I think that that's the most important point. It has to be the left circulation. And this kind of came up when we first got up and running because we have a big CTO practice. And if you look at most registries, about half of CTOs are right coronary arteries. So that was a big deal initially for us. And so there's actually a registry arm in the trial for patients that have right coronary ischemia. But for the randomized arm, we're looking for left coronary ischemia.
So that's an important biological and mechanistically important point, that it really needs to be left-sided objective evidence of ischemia. And then some of the things that are in the trial are extremely scientifically hygienic, but also somewhat problematic in terms of recruitment. And that is that, you're taking a group of patients who have refractory angina and they really need to be on stable medical therapy without any changes in their medical therapy. It used to be for 3 months. Now I believe it's down to a month. And the problem is, it's not always you making that choice, right? So refractory angina patients have frequent contact with their doctors, but it doesn't mean that they're going to have, chest pain on Tuesday at, 11 a.m. so they can call their doctor. It might be at 11 p.m. after having a bag of salty chips or something like that. They end up in the emergency room, they get their medications changed, and then we have to kind of reset the clock to get them enrolled into the study. So what are some of the tips and tricks you guys are using at Cornell? I'm going to share what we're doing at St. Francis in order to identify these patients, but then also to ensure that maintain eligibility.
Yeah, that's a huge trick because oftentimes these patients have multiple providers and we're not necessarily the main contact for that person. And when we see these patients, because we have just like you guys, we have a complex coronary practice, we're generally seeing these people for potential revascularization options. And after we've explored all of these things, we'll introduce these trials to them. And I spend a fair bit of time with them in the clinic explaining to them that, look, if this is a clinical trial, we're looking for a specific type of patient. And to be qualified for this trial, we need to make sure that these conditions are met. And without getting into too much detail with them, we try to emphasize the idea that medical therapy is one of the main entry gateways to get into the trial. You need to be on medical therapy. So we make a big deal out of having them contact our office. We have nurse practitioners that help us with all of this stuff to make sure that we're keeping their file up to date in terms of the time. Because as you said, they had to be stable for at least a month. It used to be way worse. It was 90 days, which was an impossible task.
Yeah, we ran through the same issues because it wasn't us. You can imagine the scenario where a patient goes to the emergency department with chest pain. The emergency room physician sees that this patient's got refractory angina, and then to discharge them with doing nothing seems almost negligent. And so they'll increase the amlodipine from 5 to 7.5 and it resets the clock. And so what we've done is actually give the patients either the doctor's number who's championing the study at our hospital, it's 3 physicians, or we give them a pamphlet to actually hand to the doctor that says that they're eligible and waiting for COSIRA II study. And in which case, the ER physician usually just calls us. And that's really, really helped and say, look, we're trying to get the patient in. They have frequent contact with our coordinators. So we get the coordinators to call them every couple of weeks. And that actually helps them stay focused. And also, they need a point of contact if they end up having angina.
100%. They need to have some line of communication with the study team so that they can communicate if there have been any changes and give us an update if they're just not feeling well so that we can make the change.
So the trial inclusion is also very vigorous, right? So I found it interesting that you had to do 2 treadmill tests within a week that fit within a certain criteria, 2.5 minutes to 8 minutes. And they had to be ending up within 30 seconds or so of one another to really prove that there just, wasn't an effort relation, that this was actually a limitation in exercise based on coronary artery disease. But that's been tough too, right? To get patients with refractory angina to exercise twice within a week. Yeah. How are you handling some of that stuff?
That's been a huge deal. I think that was a source of a lot of screen fails because patients and the treadmill techs all have sort of this idea that we need to run you till you can't run anymore, which is really kind of not what we're trying to do. We're trying to get an objective measure of what your threshold for angina is. And that's a concept that's sort of foreign to what a treadmill test is typically done for. So obviously we don't want to do anything that would unnecessarily sway a patient to do something that doesn't really seem consistent. But I do make a point to tell the patient, look, we're trying to figure out what type of activity triggers your symptoms so that we know what to compare it to. And I make a big deal about that so that the patient understands this is what we're testing. We're testing how much of a change we'll see in your ability to go on a treadmill before and after we do this study procedure on you. And so that helps them to understand a little bit more about what they need to communicate to the treadmill tech. And we also tell the same thing to the treadmill tech that, look, we're not trying to make a diagnosis here. This patient has refractory angina. What we're trying to understand is, what is the threshold for their angina? That's a very different question than what we typically would order a treadmill test for.
So I'm smirking because this was the first time I ever saw where our exercise treadmill tests were done in the basement of the hospital, because we basically kept having this issue where the techs would just stop the patients right away. And we had some techs were saying, keep going, keep going, keep going until you're basically falling off of the treadmill. And other techs were saying, oh, you have your first bit of chest pain? Oh, stop. So some of us actually, I went down to the treadmill and spoke to the techs and also the reporting physicians and reiterated, this patient's going into COSIRA II. The goal of this treadmill test is not to document the presence of ischemia. It's really to document their exercise tolerance. And so that totally changed the game for us. I remember, I'm laughing because of my first patient. So my first patient who was enrolled in COSIRA II, I'd known for 9 years, John, and I had put 11 stents into him. I brought him back for an angiogram basically every year. Every branch was pinched. He had objective evidence of ischemia. And the patient went to the exercise and he basically went over the 8 minutes and 30 seconds because he said, Doc, I thought you needed me to, do as much as I possibly could. And he was trying to, he was basically killing himself on there. He said he was having roaring chest pain. He actually screen failed out of the study for that. But a year later, I got him into the registry and he had an absolutely dramatic change in his symptoms. And so this is, of course, isn't unblinding because the patient's not enrolled in the study. But I'll tell you what's really interesting about him. He calls me up like 3 months later, all right? Again, I've known this guy 10 years. He calls me up and he goes, Doc, I'm having pain. And I'm like, oh man, this, it didn't work, right? And I'm honestly really disappointed. And then he says, ever since I started running in Central Park, my legs are hurting now.
That's fantastic.
I said to him, what? And I said, it's your legs, not your chest. He goes, no, my chest, whatever that thing you put in me, that fixed me up. I'm fine. I'm running now. I'm jogging in Central Park. So that's was a great story. Sort of a great story. I've shared that story with the developer of the coronary sinus reducer, Shockwave, who've shown it on a number of occasions because it's one of my favorite cases.
I've actually had a couple of cases in Cleveland that just did not want to be in the randomized trial. Just absolutely did not. They actually went off to Europe and got commercial devices put in because they just were so excited to be part of this, but didn't want to be in the trial. And so, that's been an interesting story in itself to follow up with these patients.
So what are you guys doing for referral patterns, for workflows, and maybe even interinstitutional collaborations? I got one of my first patients from Yale where they weren't enrolling. Samit Shah called me and said, listen, I heard you guys are doing the coronary sinus reducer. We're not up and running. He sent a patient all the way from Connecticut to have his coronary sinus reducer. Are you guys working on something like that? Or
we're part of a pretty big health system, kind of like you guys are. So really right now, the challenge is to get engaged with all of our local partners, because I think there's a lack of awareness even locally in terms of what's available. And so that's sort of been the main focus of what we've been engaged with. Cleveland was a little bit different because in Cleveland, our patients were kind of coming from all over the place. And they were honestly mostly coming for surgical evaluations, and they would trickle through the system, end up in interventional cardiology, and that's where we're getting the majority of our patients there. So it was a very different model entirely. This is much more of a local referral pattern, getting to know everybody and making sure that they all understand what we have to offer, because these are things that are relatively novel and not too many people have awareness of the fact that these things exist.
So how do you, let's track on that a little bit. How do you get the word out that we have this trial and this tool potentially available for refractory angina patients to the community?
Yeah, it's a huge challenge. I was wondering if you had some great ideas to share with me. Since I'm new to the neighborhood, I mean, we've done some grand rounds and we've done some presentations at the med school, but in terms of trying to understand how to reach the people that are taking care of these patients, it's a very new practice setting for me, and I don't have a lot of great insight in terms of how to break into this. What's happening, which is similar to what happened in Cleveland, is that the CTO practice is starting to build up pretty rapidly, and that naturally lends itself to recruiting patients that, you know, are either not good cancer, revasc, or they've already been revasc and have ongoing symptoms.
Yeah, so that's obviously, let's talk about a really practical challenge, right? And that is both your institution and my institution have pretty robust CTO programs. And to be honest, part of what we do and pride ourselves on is running this complex CTO program. And then becomes sort of the fine line for the clinical trial, which is coronary artery disease, which is deemed unrevascularizable. And so that's a moving target, isn't it? It might be different at different institutions. And so how do you determine, hey, I should do this CTO, it's going to be straightforward for me, or hey, you know, this is starting to get to, you know, a high level of risk, and I'm going to go for try to enroll this patient in COSIRA II. I mean, that is really tough. So I was wondering if you had any insights on this. I can tell you what we're doing now, but I'd love to hear your thoughts.
You know, I would tell you that in talking to different operators around the country, actually around the world, in terms of their impression of what this therapy could do to their complex PCI practice, you hear all kinds of things. You hear some folks describe this as a helpful adjunctive tool, which is kind of how I look at it. And yet there are other operators who feel that this is somehow a threat to their practice. And it's an interesting dichotomy. I would say that this is really part of the algorithm. And I don't really see this as anything other than as part of the treatment algorithm. From medical therapy to PCI to surgery to advanced revascularization, including CTO PCI. This is just part of that algorithm, and understanding where this fits really has to do with the patient and the operator's understanding of the risks and the technical feasibility of the procedure. We both do some pretty interesting percutaneous revascularizations, and you know that some of these things, before you even get going, that it's going to just be a slog. It's going to take hours. The outflow is going to be moderate at best. And you got to be honest with the patient, and the patient and you have to have some shared decision-making in terms of what makes the most sense, because these trials are available and a lot of these patients would be good candidates for these trials.
Yeah, I mean, what we've sort of decided to do as an institution is say, all right, let's pretend coronary sinus reducer was not available. We do attempt at revascularization as if it wasn't available. And then if the patient after revascularization either continues to have refractory symptoms or they have very high risk, like you have, you know, your non-interventional collaterals, and you're talking about a greater than 5% morbidity or mortality from their procedure, then we're really going towards enrolling them in COSIRA. And that's been successful for us. I mean, I think we have lulls too. We're on 15 randomizations, so we've got a little bit of muscle memory about the procedure too, and I think that's very good. But the main thing, honestly, that I think has made us, in quotation marks, successful in the COSIRA II trial is really involving our research coordinators and having a group of people together that are going to follow the patients through the patient journey. I'll give an example of my sort of first patient, the one who came from Connecticut, actually. He got to the front of the hospital and he had to walk from the front of the hospital to my office, which is in the outpatient building, which is about 200 yards. And he really had a lot of chest pain doing that. And I told this patient, okay, we're going to have to put you on the treadmill twice. Within a week, he lived in Connecticut. He had to come back for this procedure twice within a week. And after really having some long discussions with him and talking to him about what the pathway was going to be, was really how we engaged the patient and the coordinators on what this process entails. It's not simple. It's not like enrolling in a drug-eluting stent trial and say, hey, you want drug-eluting stent A or drug-eluting stent B, and we're just going to check which one is different. It's not even like a drug therapy where you take a tablet or a shot once in a while. This is really a pathway, okay? You're going to need to have an angiogram within 12 months that shows that you have unrevasculable coronary disease. You're going to have to document left-sided ischemia. You're going to have to be on a stable medical regimen for 3 months without a single change, now a month without a change in your medical therapy. You're going to have a treadmill with reproducibility within 30 seconds. There's a lot to get enrolled in this trial. And so it's important to really have a high quality research team and really have a research coordinator champion who's going to follow these patients and stay in touch with them to make it successful.
100% agree. It's just not possible. This is such a longitudinal process to get this done.
So in our last few minutes, I want to steer away from the type of disease that you and I are often treating, which is clearly obstructive coronary artery disease, and go into this sort of abyss of microvascular disease and the potential of this. So some studies show that up to 40 to 50% of patients with angina with no obstructive coronary artery disease actually have microvascular disease. And there is emerging evidence that the coronary sinus reducer doesn't really care if your ischemia is in the epicardial or microvasculature, and that this could be a therapy for those patients. What's your thoughts on that, and what potential impact do you think that this could have in the field for this really difficult to treat patient population?
I think that that's probably the most exciting development in this therapy. So I think Amir Lerman's paper is probably the one that is the, leading to the charge in terms of understanding how this could work. So not only describing a much larger patient population to treat, but maybe even getting at exactly what this thing is doing mechanistically to help treat angina. So, his paper shows some compelling evidence that for patients with microvascular dysfunction, whether it be endothelial dependent or independent dysfunction, that a coronary sinus reducer can effectively correct that dysfunction in a way that helps patients feel better and is objectively measurable in the cath lab, which is fascinating because this is sort of like getting at understanding what it is that this device is actually doing and identifying a much larger population of patients that could be treated.
Yeah, it's the other major study to talk about in that context is the orbitocosmic study by Rash Alami, and that was published in The Lancet. So this was a proof of concept, double-blind, randomized, placebo-controlled trial. It was just 51 patients, but that was done in the UK for patients with refractory angina, class 3 or 4 symptoms, fully optimized medically, previously revascularized. And they found that using in a sham study with a very carefully controlled measurement of angina using an online mobile app, that the coronary sinus reducer reduced daily angina episodes by almost 40%, with almost the probability of benefit being almost 100%, which is amazing. But they didn't find an improvement in stress myocardial blood flow.
Which was their primary endpoint, right?
Right. And so it's really interesting to me that either we don't have the tools that are sensitive enough to be able to pick up whatever changes are being done by the coronary sinus reducer, or whatever's happening is happening on the ultrastructural or microstructural level that we're unlikely to be able to pick up.
Yeah, certainly below the segmental myocardial segment, the measurement units for an MRI don't seem to be sensitive enough to understand, because they did describe this redistribution of blood flow in ischemic zones with a ratio of subendocardial to epicardial flow improving, right? So could that be part of it? But this seems to be beyond the sensitivity of the MRI to really measure in an objective way.
How much does that bother you? For you to really put this on the shelf, do you need a mechanistic outcome, or are you okay with the hydralazine approach and say, well, it seems to drop blood pressure some, I don't know how, but I don't really care?
Yeah, I think I'm somewhere in between, right? We all take care of these patients where you've thrown the kitchen sink at them and they're still having angina. So this is something that's relatively low risk and uncomplicated that you can offer them. So certainly it's compelling in that way. But having some mechanistic understanding of what this does certainly helps to make it an easier pill to swallow, right?
So tell me, what's the future of the coronary sinus reducer in 5 years? The trial's done, it's positive, shows exercise tolerance testing is improved. We figure out some more mechanistic data. Where do you see this in clinical practice? Is it a procedure that's done every day? Is it a procedure that's done every week?
I think that this is going to be a regular part of our treatment algorithm for patients with angina that's refractory to medical therapy. So patients that have symptoms that break through good medical therapy are going to be sent to the cath lab. We're going to determine what the revascularization strategy should be. And for the patients that are revascularized or cannot be revascularized, this is going to be part of their algorithm for how to treat them.
Well, Jack, this was fun, man.
It's great.
It's a good way to spend a Saturday morning talking about refractory angina. I want to thank everybody from BackTable who took the time to listen. We had a good time talking about the coronary sinus reducer and its potential impact in the field. For those of you who are interested in participating in or becoming an investigator for COSIRA II, the trial is run by Shockwave Medical. They're still looking for sites potentially, but the trial is moving forward. And I'm just going to leave you with the thoughts that this is a major iteration. There haven't been that many device iterations for coronary artery disease patients in 20 years. And the fact that we have something I think is both exciting as well as rejuvenating and invigorating, because we might have some more options for our refractory patients. So thanks again for joining us all. Have a good day.
Thank you, Ziad.
Thank you so much for joining us on BackTable Cardiology.
If you have not already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend.
If you have any questions or comments, direct message us at _BackTableCards
On Instagram, LinkedIn, X, TikTok, Blue Sky, or YouTube.
BackTable is hosted by Hadi Lisha
And Sami Saifo.
Our production team is led by Kieran Gannon,
Aaron Bowles.
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for tuning in.
We'll see you next time.